So we're going to be talking about traumatic optic neuropathy treatment. And of course, it's really important to make the diagnosis first for TON, traumatic optic neuropathy, before you can start thinking about treatment. The patient has to have the trauma, of course, and the trauma should be commensurate with having a traumatic optic neuropathy. The most common traumas that we see are different than the open globe injuries, which actually perforate the globe. They're usually injuries to the forehead, and the reason is the orbit is shaped like a triangle, and the force, when it hits the bone, is transmitted down to the canal. And so it's thought that edema in the closed space causes a compartment syndrome, and that force wave is transmitted to the canal that leads to the localized edema that causes traumatic optic neuropathy. Versus injuries that occur directly on the globe either cause a perforation injury or a blowout fracture. And so normally it's like fall over the bicycle handle, you go over the bicycle handle and you hit your head right here. Or it's a car accident where you hit your head right there on the windshield or the steering column. So in order to make the first diagnosis of traumatic optic neuropathy, you have to make sure it's not an open globe first, and that usually is an easy enough task to do, but you have to do a full eye exam to make sure it's not an open globe or a floor fracture or the usual things. Once you've made sure it's not an open globe, then you're going to be looking at the eye for the critical finding, which is the relative afferent pupillary defect. Usually it's unilateral, but it can be bilateral traumatic optic neuropathy. But if you see this RAPD, that's usually helpful. And we want to look in the back of the eye. Normally the fundus is normal. Sometimes we can see hemorrhage or avulsion of the optic nerve, depending on the mechanism of injury. Sometimes the disc is swollen, but usually it's a retrobulbar optic neuropathy because the problem is in the canal. So normal fundus, RAPD, decreased vision in the setting of appropriate trauma. That's how we make the diagnosis of traumatic optic neuropathy. And our first imaging study, of course, is going to be CT because we're looking at bone. We're going to be looking at the head and the orbit for fractures and other injuries. Most of the time in traumatic optic neuropathy, the CT scan doesn't show anything. However, it can show lesions that are surgically treatable, and that's why you should do the CT of the orbit in the emergent setting. The treatable etiologies are a bone fragment hitting the optic nerve. Well, that should be removed. Or if you have hemorrhage in the sheath or a retrobulbar hematoma. Those are going to present with proptosis and elevated intraocular pressure. Those are surgically treatable. However, if no lesion is seen, or it's just a fracture in the canal, then you have choices. And your choices are optional because there is no proven effective therapy for traumatic optic neuropathy. The treatments that have been used in the past mostly surround steroids or surgery. And the steroid dose, route, duration, quite variable across the literature. There's never been any proof that any specific dose, route, or duration makes any difference in traumatic optic neuropathy, whether it's low dose or high dose or medium dose or mega dose or industrial strength dose. It really doesn't matter. Surgery, I limit to sheath hematoma, fracture poking my eye nerve, or they had a lucid interval and they're getting worse, or retrobulbar hematoma. Those ones I think you could argue for surgery. Otherwise, we're really not recommending decompressions for typical traumatic optic neuropathy outside of those settings. The steroid has some risk, and you need to know about two studies. One is the International Optic Nerve Trauma Study, which was a prospective initially study, but then it had to be converted over to an observational study because there weren't enough patients recruited. So in that study, that's where there's no route, duration, or dose came from. No dose, route, or duration of steroids was proven to be more efficacious than another in the International Optic Nerve Trauma Study. The second is CRASH. And CRASH is the corticosteroid randomization after significant head injury study, CRASH. In the CRASH study, optic neuropathy was not what they were looking at. What they were looking at was significant head injury. And what they randomized was corticosteroids randomized after significant head injury, thus the name CRASH. In the CRASH study, the primary outcome measure was death. And so patients who had significant head injury who had steroids were more likely to die, even accounting for severity, mechanism of disease, duration, etc. And so therefore, based on the CRASH study, you should be careful about giving steroids to patients who have traumatic optic neuropathy if they've had a significant head injury. In the CRASH study, that was defined as a Glasgow Coma Scale of 14. So if we have 14 or less on the Glasgow Coma Scale, you should really be thinking twice before giving steroids to a traumatic optic neuropathy. So you need to know a little bit about traumatic optic neuropathy. It's diagnosed clinically, RAPD normal fundus. Make sure there's no open globe, exclude other injuries. Check that Glasgow Coma scale and have a discussion, informed consent on steroids, and reserve surgery for things that are surgically amenable. Sheath hematoma, fracture, bone fragment in the nerve, retrobulbar hematoma.